we will move to the next speaker. هنقدم الأستاذ الزميل الفاضل الأستاذ الدكتور حسين الفيشاوي. الدكتور حسين will speak about intradialysis hypertension in end-stage renal disease as regarding the epidemiology, pathogenesis and treatment. اتفضل يا دكتور حسين.
طبعا
ربع ساعة.
I would like to thank my dear professor Dr. طبعا محمد غني for his kind invitation for me. وانا دايما ما بعتبرش القلب والكلى اسمين منفصلين، لان احنا معظم شغلنا بيبقى مع الكارديولوجيست، ويمكن علاقاتنا مع اكتر سبيشاليتي اكتر من التشست والنيورولوجي والجي اي تي هم الكارديولوجيست. النهارده اتكلم على very important topic intradialytic hypertension. The talk outline clinical definitions, target blood pressure in hemodialysis patients, prevalence of intradialytic hypertension, cardiovascular risk and mortality outcomes, potential pathophysiologic mechanisms, and therapeutic strategies. What is the target blood pressure? This is a very great important issue because we have failed as a nephrologist to find a target blood pressure. And in 1999, a very important article, hypertension in the hemodialysis population, high time for answers. A lot of questions without answers. They have failed, so they have made a very important meeting in the 90s, known as the GOPSET meeting, which is the initials of good old boys sitting together and talking, and the agreement, there is no agreement. And it was a very aggressive fight between them. طبعا تفاصيلها مش هنحكيها، وقالوا ايه التفاصيل دي كلها. وكانت الراشونال one blood pressure doesn't fit all because we have several types of patients, several etiology, several complications, and several ethnities, and of course several comorbidities. So what is the target blood pressure? The Kirugi 25000 guidelines قالت the pre-dialysis target less than 140/90, and post-dialysis target is less than 130/80. And this is the only time that the target has been put in hypertension in dialysis patients. 2006 do not recommend specific blood pressure targets in hemodialysis patients. 2007 targets for patients on hemodialysis are not recommended. 2015 the current paucity of clinical trial data doesn't allow defining the target pre-dialysis, post-dialysis, or ambulatory blood pressure for hemodialysis patients. The KDIGO guidelines have escaped to mention blood pressure targets in hemodialysis patients. Why? We have weak soft evidence, small number of patients who were tested by different studies, conflicting and contradictory results. Study design may not be strong enough. So that this controversy, this scarcity of evidence, no randomized prospective trials, usually it is extrapolated from the non-dialysis patients population, ideally be set individually based upon the patient's cardiac, neurological status, comorbid, age, nutrition, and others. What is the definition? So that we have no definition for hypertension in that patients. So that how you can define the intradialytic hypertension. This is a great problem really. Usually with dialysis, we are making ultrafiltration. So my expectation that there is a drop in the blood pressure, hypertension. But here, there is increased blood pressure, so that it is a paradoxical hypertension. Enrig told us that if there is increase of systolic blood pressure more than or equals 10 millimeter mercury. Others, 15 millimeter mercury increase of mean arterial blood pressure between the start and the end of hemodialysis session. Third, blood pressure is higher at the end of the dialysis session than at the dialysis onset, more than 50% of the dialysis sessions, not only one session. Gonal, blood pressure exceeds initial values during 4 dialysis sessions in a row. Show normal or high blood pressure at initial dialysis, followed by a mean arterial pressure increase of 15 millimeter mercury during more than 2/3 of the most recent 12 treatment sessions. Chen, hypertension that appears resistant to ultrafiltration and which occurs during immediately after the dialysis procedure. All these are definitions. So that a sustained increase of blood pressure during the dialysis session with blood pressure values during and at the end of the dialysis session exceeds blood pressure values at dialysis onset. Other definitions not accepted, blood pressure rise of any degree during the second or third intradialytic hour, or worsening of pre-existing hypertension or new onset hypertension after administration of erythropoietin stimulating agents. So that there is no uniform definition of intradialytic hypertension. And because of that, each one designing a paper taking a certain definition and or a certain protocol so that we have no, of course, approval for this. So that a sustained increase of blood pressure during the dialysis session with blood pressure values during at the end of the dialysis session exceeding blood pressure values at dialysis onset. So that we are not convinced that it is necessary to frame this definition with strict numbers. The repetition of the phenomenon over the sessions must alert the physician and trigger clinical decision. Great problem. The hypertension prevalence in chronic hemodialysis patients, about 77.5%, ranging from 6 to 90. 61% of them have antihypertensive medications. Blood pressure was unsatisfactory. Who survived longer on hemodialysis were less likely to have hypertension. What is the patterns of intradialytic blood pressure behavior? Most of them usually you have expected blood pressure course with variability. شوية يعلى وشوية ينزل. Episodes of severe hypotension during that session which can be dealt with. The lesser incidence with blood pressure caused with variability at a higher level. Let us go to the prevalence. Prevalence, usually it occurs in patients starting dialysis known as incidence patients, but it may occur those on prevalent dialysis for months and years. The intradialytic hypertension occurs in 5 to 15 of treatments, but some papers reach to 20, 22, and 30%. So that, let us see the CLIMB study. Very important study. They have adopted that 53 of the patients will have hypotension more than 10 millimeter mercury per decision. 34% of the patients from positive 10 to minus 10 millimeter mercuries, and more than, and about 13%, this is the intradialytic hypertension that have increase of blood pressure more than or equals 10 millimeter mercury. So that in this CLIMB study, they have found that the incidence of hypertension, intradialytic hypertension, is 13%. Another study, wave 2 study, have found that intradialytic hypertension is the majority, 42%, while intradialytic hypertension is 12%. As we can see, this is the 12% which have been prescribed in the wave 2 study. What is the importance of that? What is the risk? They have found that if you have intradialytic hypertension, you have poor outcomes. This is a very, very characteristic and classic curve known as the U or the J-shaped curve. If you have systolic blood pressure below 110, you have a higher mortality rate. If you have the systolic above 180, you have higher mortality rate. If you have the diastolic above 110 millimeter mercury, you have also a higher mortality rate. The low blood pressure, I'm not concerned about the low blood pressure. I'm concerned what's behind it. Usually, it is associated with other comorbid conditions, such as major cardiovascular disease, such as heart failure, malnutrition, inflammation, Kashicha syndrome, and the situation with hypotension, like sepsis-like, and left ventricular dysfunction. And all of these are fatalities. As we can see in this diagram, usually the rise of the systolic blood pressure is more serious than the drop of systolic blood pressure. To reach a mortality, you have drop of systolic blood pressure more than 30 millimeter mercury. But rise of 10 millimeter mercury is very catastrophic for our patients, as we can see here. Intradialytic hypertension is associated with high mortality. As you can see in this diagram, the patients that develop intradialytic hypertension are at a higher mortality rates. The incidence of stroke is increasing about 5 times. The incidence of cardiovascular events have increased more than 4 times, so that it is catastrophe. As we can see in this study, wave 2 study, as we can see, with intradialytic hypertension, the all-cause mortality is about 37%, while the cardiovascular mortality is about 62%. And as you can see, the rise of systolic blood pressure, 10 minutes or more, will have, of course, in this situation, with a lower survival probability and a higher mortality rate. This is another study have adopted that when you have rise of systolic blood pressure, you have a higher mortality rate and increase annual hospitalization hazards and mortality. And our patients, when they are in dialysis with hypertension, usually the more the blood pressure, of course, the higher will be the mortality rates. This meta-analysis was very important. They have mentioned in any rise of blood pressure. 10, more than 10, more than 20, from 0 to 10, all cause mortality. So we are speaking about a very serious issue. Not that only. The intravenous hypertension is associated with left ventricular mass in the PID study. They have found that this increase, of course, and cardiologists understand that very well, is one of the predictors of mortality. When you have a high blood pressure, of course, you have a sort of pulmonary congestion, you have a lower oxygen saturation. Lower oxygen saturation will make more hypertension, the process will be perpetuated and, of course, increase mortality rate. Let's speak about potential pathophysiologic mechanisms. Volume overload is the main cause of intradialytic hypertension. Because of that, volume is very serious regarding history, examination, IVC, chest X-ray, ultrasound lung, impedance device, and so on, proBNP and biomarkers and others. They have found that usually we can rely upon the bioelectrical impedance for detection. Why? Because we have found that patients who were diagnosed as euvolemic and we are making ultrafiltration, most of them, when we have made the bioimpedance device, we have found that they have volume overload. So that the problem is increased salt intake, thirst, increased water, volume overload, chronic volume overload. The problem that during dialysis, you are making ultrafiltration from the intravascular, but those inside the tissue spaces after dialysis are going to be transferred to intravascular and a process of chronic hypertension. And this is usually not occur. Refilling from the tissue space. When you are making modest ultrafiltration, you are decreasing volume overload according to Starling law, improving the cardiac function, and the blood pressure may rise. But excessive, of course, ultrafiltration may produce hypotension, but don't miss that sometimes excessive ultrafiltration, you may stimulate the sympathetic nervous system and make vasoconstriction with severe hypertension, and here the solution may be IV isotonic saline. So, proper assessment of my dry weight and how I can solve these problems. Either by extended dialysis sessions, such as 3 times per week, every 68 hours, or short but repeated session, about 5 to 6, up to 7 sessions per week, every session 2 to 3 hours, yes. Here, as we can see, ultrafiltration in the DRIP study usually decrease the blood pressure. But you should make sure that you didn't take a residual volume that will make chronic hypertension later on. Here the solution is prolonged or more frequent hemodialysis session. As you can see, in this study, long slow hemodialysis patients have improved these patients. Another study that patients with long or short repeated dialysis sessions also have been benefit from that. This is another study with the same issue and meaning. So that hemodialysis home is very important because we are in Egypt. Usually you have only 4 hours, 3 times per week. So that long hours home hemodialysis may be the best renal replacement therapy method, but this is not available for all population. And this was addressed in this study, and it was very beneficial really. Here, the European Best Practice Guidelines, LET, dialysis treatment time and or refractory should be increased in patients who remain hypertensive despite maximum possible fluid removal. So that I should increase the rate, the duration or the frequency of the dialysis sessions. What about 2006 guidelines? They have adopted that longer increased ultrafiltration, longer dialysis, more than 3 dialysis treatment per week. This is another guideline showed that when you have paradoxical hypertension, you are in need for longer dialysis sessions or frequent dialysis sessions. And this is the guidelines have mentioned that one of the main line of therapies is prolonged slow ultrafiltration, or of course, and you can make short treatment visits. So that volume overload, proper assessment of dry weight, and extended dialysis sessions daily or daily short sessions. What about net sodium gain? We should check that pre-dialysis sodium level to minimize sodium gain. As you can see, in this situation, with increased sodium on the dialysis session, of course, there will be increased hypertension. So that one of our solutes on dialysis, we are treating that we may make decline gradually of sodium up to reaching 135, because the classic is 140 millimeter mercury. And they have found that if you have higher sodium, you will have higher intravenous hypertension and, of course, higher mortality rate. So that in the guidelines, as you have mentioned, decrease sodium intake and low dialysate sodium over the machine. What about else? Removal of antihypertension medication. Some people have a fear that hypotension will occur during dialysis, so that they tell the patient, don't take the drug during. We'll discuss this later. We'll make it nocturnal to avoid that. And we should check the dialysability of these drugs, such as carvedilol. As you know that this is the classic. This is the classic. ان انا ببدا طبعا ACE inhibitors, calcium blockers, ممكن add beta blocker or clonidine, which is very effective, وممكن احط minoxidil. This is the timing. Drug dialysability is very important. I should choose those who are not dialysable, such as the ARBs, beta blockers, especially only carvedilol and dibetalol, and calcium channel only amlodipine, and small percent of ACE are not dialysable, and the clonidine. This is the table طبعا that show which drugs of least dialysability. Of course, when I'm checking or choosing my drug, I should make it in clinical situation. This is not, of course, sympathetic overactivity activation of RAS system. In this situation, inhibition of RAS, and I'll give adrenergic blocker, and the best is, of course, carvedilol, and you will know why this carvedilol. This is have mentioned that we have more norepinephrine in intravenous hypertension patients and more renin level, and the same in this endothelial cell dysfunction. They have found that this is very important. In intravenous hypertension, usually the patient has higher endothelium level and decreased nitric oxide. We have lost the balance between these two issues. With increased endothelium, more vasoconstriction and more hypertension. Why? Because of the uremic toxins have made decline of endothelial progenitor cells, which is responsible for the repair of the endothelium with injury and endothelium release and hypertension. So that normally we have the balance between endothelium and nitric oxide, but we are losing this balance in case of enteral hypertension, because this situation, loss of progenitor cells or decline will decrease repair, increase endothelium, while increased sodium will suppress nitric oxide production in this situation. Here, we are against the guidelines. Here, the drug of choice is the beta adrenergic blocker antagonist, which means a blocker agent, such as carvedilol, coming next calcium blocker, such as amlodipine, ACE and ARBs, and direct vasodilator. For endothelial cell dysfunction, if it is highly proved, we can use a specific endothelium-1 antagonist, such as avosintane, but it is not approved by all personnel, or making carvedilol or RAS have indirect inhibition of endothelium. Maybe hypertension due high ionized calcium, so that please decrease the calcium level in the dialysate. Maybe due to hypokalemia, so please in this situation increase slightly the potassium in the dialysate. ESA was previously taken intravenously. This stimulates in this situation the endothelium with hypertension, so that please give here the ESA after dialysis, and it must be given subcutaneous. Low oxygen saturation because of the congestion, and the decline of the oxygen, of course, will increase hypertension, as we can see in this study. What else? Hyperaldosteronism. In spite that use are not acting, here I'm not giving aldosterone, such as spironolactone. I am giving it to antagonize the action of sodium, so that to decrease, to improve sodium, nitric oxide release. High magnesium is responsible, so that please decline the magnesium. For other metabolic disorders, if you have significant alkalosis, this will make. If you have mild acidosis, this will increase blood pressure. Sometimes you may add glucose in the dialysate to decrease, of course, blood pressure. Hemodialysis procedure. If I have made everything and I have failed, here, please switch to peritoneal dialysis, because it's more physiological with continuous of fluids and sodium. This is a paper, our study, showed us that with peritoneal dialysis, we have been improved these studies. In resistant hypertension, bilateral nephrectomy have been, of course, adopted. And this is not only, as mentioned Professor Dr. Muhammad, resistant hypertension, previously surgical sympathectomy because the correlation between, of course, the sympathetic system and the kidney. But more recently, catheter-related renal denervation or catheter-based, the device for power reflex activation. And in this situation, central AV anastomosis, so that I can do this. Still, I have made all of that, and I have still resistant hypertension. Here is coming the magical solution, which is kidney transplantation. I have several cases. I have made them everything, no response, until they have been transplanted. They became hypotensive, وعندي لسه أنا اسمها عبير زرعها hypotensive، وعندي مشكلة معاها إنها بديها دلوقتي ترفع الضغط دلوقتي. Excessive ultrafiltration below dry weight, it is very critical. In this situation, you should give isotonic saline, but please don't try it اللي غير من خلال very expert، لأنه hypertension وميزد وبيديله saline هيعمل له cerebral hemorrhage. Therapeutic strategy, as we have mentioned, volume management, inhibition of sympathetic, inhibition of RAS, pharmacological management of endothelin, antihypertensive regimen, ESA, adjustment of dialysis prescription, so that you can treat your patients all by the same way. You should choose the line of therapy according to the underlying expected pathogenesis and mechanism in this situation. And very important to control blood pressure by the right way to improve your clinical outcome, to decrease cardiovascular mortality in this situation, so that في الهيمودياليسيس decrease dialysate sodium. خلاص انا فاضل لي one slide. Decrease dialysate calcium, decrease magnesium dialysate, increase potassium dialysate, avoid IV erythropoietin, avoid removal of hypertension, give it at the night so that it will make the surge over the night. At the morning, the patient will have good blood pressure. Not before dialysis, it may lead to hypotension. Patient factors, you will give RAS, you will give beta blocker. You can give alpha blockers such as carvedilol, both beta alpha blockers. You can give endothelin antagonist. You can make proper assessment of the dry weight and decrease sodium gain in this situation to avoid, of course, the problem that you can switch, of course, to peritoneal dialysis, kidney transplantation. So from the end, volume overload, net sodium gain, removal antihypertensive medications, sympathetic overactivity, endothelial cell dysfunction, high ionized calcium, hypokalemia, and hypermagnesemia, and of course metabolic alkalosis, mild metabolic acidosis, depleted sodium glucose dialysate, ESA in this situation, IV, pulmonary congestion with low oxygen saturation, hyperaldosteronism, hemodialysis procedure, switch to peritoneal dialysis, other such as surgery, nephrectomy, sympathectomy, devices, renal derivation, and kidney transplantation. And in this situation, if the patient is markedly depleted, give IV sodium saline. Intradialytic hypertension is an under-recognized marker of increased risk for morbidity and mortality among maintenance hemodialysis patients. ده شايفه الضغط عالي شويه، عالي 10 مللي ميركوري في الجلسه، ايه اللي هيحصل؟ لا ده يحصل طبعا كوارث زي ما شفنا. Intrahypertension is an unusual expression of excessive fluid overload. It is efficiently corrected by fluid removal, careful attention to the optimal dry weight body weight. TRC dysfunction appears to be a major mechanism underlying this phenotype. Select antihypertensive medications timing and visibility for these drugs. Improving our knowledge of this complication will contribute to decreasing the high burden of cardiovascular complications. And thank you.
Thank you, Professor Dr. Hussein, for this informative talk. For the sake of time, we have to conclude the session. We need to thank Professor Dr. Muhammad Abdelghani and the organizing committee for their nice invitation, and we hope to meet in several meetings as we have so many issues.
شكرا دكتور حسين. وهو الحقيقه النهارده السيشن ده هي كانت جميله وفتحت نفسنا ان احنا نقعد مع بعض اكتر ونتكلم اكتر في مجالات مختلفه جدا. زي ما حضرتك قلت احنا كتير جدا عيانين بيننا وبين بعض، فشكرا جزيلا وشكرا لحضراتكم. شكرا جزيلا.